Hello, thank you for joining today's NCCN webinar for patients Pediatric Acute Lymphoblastic Leukemia. My name is Tanya Fisher and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon, and if you ordered a free book when you registered for this webinar, you should be receiving it shortly. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of this presentation. This brings us to the presenters for today's webinar. All of our presenters are from St. Jude Children's Research Hospital, the University of Tennessee Health Science Center. I'm very pleased to introduce Dr. Hirota Inaba. Dr. Inaba is a member of the St. Jude faculty, director of the Pediatric Hematology Oncology Fellowship Program, and interim director, Leukemia Lymphoma Division of the Department of Oncology. Following Dr. Inaba, we will hear from Ashley Holland. Ashley is a family nurse practitioner. And our third presenter today is Dr. Brad Muller, Pediatric Hematology Oncology Clinical Fellow and Patient Advocate. Now I will turn it over to Dr. Inaba.
My name is Hirota Inaba. I'm a leukemia doctor. I'm going to talk about clinical aspect of pediatric acute lymphoblastic leukemia. I divided to 5 issues. One is a presentation of acute lymphoblastic leukemia, and diagnosis, and therapy, and side effects, and new therapeutic opportunities. So this is a blood smear of the leukemia, acute lymphoblastic leukemia, which is 20% of pediatric cancer and the most common cancer among all the pediatric cancer. So we make blood cells in the bone marrow. It's a closed environment. And then in the bone marrow, we make many kinds of cells, such as lymphocyte, red blood cells, erythrocyte, neutrophils, granulocyte, platelets, and then monocyte. These cells are working in our body. So bone marrow make these cells from the stem cells. Stem cell divide to lymphoid and myeloid. Lymphoid are divided to B lymphocyte, which make antibody, and T lymphocyte, which produce chemical called cytokine or kill the cells. And the granulocyte fight against bacteria. Monocyte find and eat germs or abnormal cells and start immune system as antigen-presenting cells. Erythrocyte carry oxygen and platelets stop bleeding. So leukemia also happen in the bone marrow, but there are some gene changes happen to leukemia happen. First mutation typically block the maturation, means cannot make a final product and become immature. Acute lymphoblastic, blastic means immature. Many pediatric cancer are immature, like a neuroblastoma, retinoblastoma. So this is a very typical future of pediatric cancer. But this is not enough to cause cancer. This usually happens in utero before the birth, and quite a number of babies are born with this clone, but many don't develop leukemia because they need additional mutation called second mutation that gives a growth and survival. This usually happens after the birth. And then leukemia cells grow in the closed space of bone marrow and then take the space for the normal cells. Therefore, these cells decrease in number, and then patient present with a bruised petechiae because low platelets, anemia, fatigue because low red blood cells, and then fever infection because of leukemia or decreased white cells that fight against infections. Sometimes patient present with a bone pain because pressure inside the bone marrow is so high because the leukemia cells growing. So normal bone marrow, we have a variety of cells making many kinds of cells. However, leukemia cells are only one population grow. These are abnormal cells. Therefore, normal population decrease, and then this is leukemia developed. So how do we make a diagnosis of acute lymphoblastic leukemia? One is important medical history, and then physical examination, such as bruise, anemia, or big liver, or big spleen, or other signs. And then typically we check the CBC, complete blood counts, and then blood smear, and the chemistries. This is one example of CBC of the newly diagnosed acute lymphoblastic leukemia. WBC 81,000, hemoglobin 3.4, it's low, it's high, and then platelet 27 is low, and then we see 94% blood cells. So this is one of the example of CBC at presentation of acute lymphoblastic leukemia. We also get chest X-ray. This is a normal chest X-ray, but some patient is having a big mediastinum, a thymus mass. This is the one sign of T lymphoblastic leukemia or T lymphoblastic lymphoma. This is kind of risky because it can compress airway or blood vessels. And then once we diagnose and then we suspect, and if patient is stable enough, we do the bone marrow aspirate and biopsy. First, microscope can see the shape of the cells, and then flow cytometry to define B or T or myeloid cells. And then I'm going to explain later about genetic testing, and then we evaluate minimal residual disease. And then leukemia can invade to spinal fluid. Therefore, we do spinal tap, and then at the same time, we give an intrathecal chemotherapy. Incidence of acute lymphoblastic leukemia is about 6,000 new cases per year in the US, and then 1.7 per 100,000 per year. These are the incidence. And then this is a pediatric disease because 60% of ALL happen under age 20 and peak age of 2 to 5 years. Male has slightly more than female, the ratio is 1.3 to 1. And then also there's a difference in the incidence of race and ethnicity. And then it is high in Hispanic and Caucasian population compared to African American and Asian. And there's a difference between Hispanic boy and the African American girls, more than 3 times difference. Treatment is long, 2 to 2.5 years of treatment, comprised of induction, consolidation, and continuation. Continuation can usually include delayed intensification, another stronger part of therapy. Dose and schedules are very optimized. We use leukemia risk classification that change the dose and schedule. Also patient factors, how much side effect, how drug is metabolized, we call pharmacokinetics. Also genetics are used to adjust the chemotherapy. We are using these medications. These are approved by FDA before 1980s. Majority of medication that we use now is approved long time ago, but we are optimizing these dosing and schedules. This is Senju data. This is the x-axis, the years from diagnosis. Y-axis is the how many percentage of survival. When Senju was built in 1960s, only 21% in 5 years can survive after diagnosis and then drop more. we are now the level of 94% of the 5-year survival. It's significantly improved. Because of, we do good risk stratification now. We use several factors for the risk stratification. One, we use clinical factors at diagnosis. Age 1 to 9.9 years is better than less than 1 or 10 years or higher. White blood cell counts less than 50,000 is better than 50 or higher, 50,000 or higher. If patient has a central nervous system or testicular involvement, which is considered to be higher risk. And then I'm going to explain about genetic analysis, which is now we use for risk stratification, and also respond to therapy we call minimal residual disease, MRD. If patient to be considered to be low risk, we decrease the chemotherapy intensity to decrease side effect. If patient considered to be higher risk, we're going to intensify therapy to decrease the relapse risk. So genetic analysis, typically we check the gene in the normal cells, typically skin tissues or blood cells when patient is in remission. And then we also check the gene in leukemia. When we talk about gene in leukemia, we compare this gene, leukemia gene, and normal cell gene. So B minus A is the difference that is happening in the gene changes in leukemia. Leukemia is one disease now, but by checking genes, we are dividing this leukemia to more than 20 subtypes, 20 groups and also this is important. These genes, ETB6-RANX1 and high hyperdiploid, are associated good chance of survival compared to BCL1, BCL1-like or others are considered to be higher. So this gene information gives us some idea of the how risk factors. Also, I'm going to explain about minimal residual disease. For example, if I go to we have a Memphis Grizzlies in Memphis now. If I go to Miss Ashley Holland and Dr. Mueller to go to game, and then if I have only binocular, it's like a microscope, I see many similar people there, and it's very hard to find among these more than 10,000 people. But if I have a cell phone, I can get it very easily by calling number because I know specific number. Similar thing we use for the leukemia detection for the minimal residual disease. I also show example with a microscope like a binocular in the game. At diagnosis, it's very easy to, relatively easy to find leukemia because majority is the big cells. These big cells are leukemia. And after chemotherapy is given, we still see these kind of big cells. And even experienced pathologists, they cannot tell whether this is the leukemia cells or whether this is a baby immature regenerating cells. These cells are already matured cells. So, there are quite a number of young cells like this. Threaded color is different, but size is similar. And then when we use this MRD method, actually these are all normal baby cells. It was not leukemia. So slightly microscope has limitation. And then we use leukemia unique phenotype by using machine called flow cytometry that can go down to 1 out of 10,000. PCR, polymerase chain reaction, can go to 1 out of 100,000. And next generation sequence can go down to 1 out of 1 million. Because this is important. If one cell left over in the body, leukemia may come back. So it is important to check this MRD, minimal residual disease, during the therapy, or even at the completion therapy. Ms. Holland explained about side effect, but short-term side effect is mostly worry about infections, and then this is caused by bone marrow suppression, need a transfusion. Nausea, vomiting, hair loss, and the others. Long-term obesity, decreased bone density. So even leukemia is cured, we have to follow whether patient does not develop these kind of side effects. And then also, it is important that these side effects can be different between patient A and patient B. Some family comes to us, my son or my daughter has a lot of side effects compared to other child that I know. But why is it? Because everybody different. If we at this moment we give a same dose of chemotherapy, but in the future we have to adjust the chemotherapy based on individual factors. And partly we can do that by checking genes, because these genes in normal cells are showing that represent individual characteristics. That gene in individual cell, individual people may explain partly the side effect, extent of side effects. So we are adjusting chemotherapy at this moment in many factors, because side effects are different between patients. And we do dose and schedule adjustment. One is if patient developing a lot of toxicities, a lot of neutropenia, or some more side effect, we're gonna decrease the chemotherapy. And also sometimes we measure the drug levels. If patients metabolism slow and then accumulate the medication, we're gonna decrease. We use we call pharmacokinetics. We also now start checking genes that is important for drug metabolism. We call pharmacogenomics. For example, we give medication. Before that, we check the genes. And then if we, by checking gene, if we predict toxicity is intermediate, we keep the regular dose. If we predict toxicity is high, we're gonna decrease the dose. If toxicity is expected low, we may sometimes increase the dose. These genomic gene-based modification chemotherapy is now being done for these two chemotherapy, 6-mercaptopurine and 6-thioguanine, by checking TPMT, thiopurine methyltransferase, or NUDT15 genes. So I'm going to talk about, last several slides, a new therapy approach in acute lymphoblastic leukemia. Now people are thinking about target therapy, especially molecular target therapy or immunotherapy, to attack leukemia specifically, and then hopefully keeping normal tissue not affected much. And then this can lead to dose reduction or removal of currently ongoing conventional chemotherapy. So this is a survival curve I just showed, years from diagnosis and survival in the y-axis. But when you look at carefully here, 2000 to 2017, survival is no remarkable change. And then we are always looking at 100% cure. So to go to 100%, it seems like there's a limitation of conventional chemotherapy. If you just increase chemotherapy, probably just increase the toxicity, may not lead to better outcomes. So as I showed, all the medication that uses before 1980s, we have to move to newer approach, such as molecular target therapy, imatinib, dasatinib, ponatinib, or immunotherapy, which is blinatumomab, CAR T-cell, and inotuzumab. Molecular target therapy, now we are understanding genomics and what is causing leukemia. Hopefully we understand more. And then by understanding this, we can attack the specific abnormality that driving leukemia. At this moment, small fraction can be used, such as BCAV1 and BCAV1 like. BCAV1 leukemia is chromosome 9, one of the chromosome, and the other chromosome 22 are break here, and then make a new combination, like this one and this one bind to make a new one for BCR-ABL protein. This protein tend to bind to ADP, that's energy, and produce a lot of ATP, and leukemia become very aggressive and become resistant to chemotherapy. But if we have a medication such as imatinib, bind here and then prevent ADP, ATP to coming here, and by doing so, leukemia become less aggressive by giving a chemotherapy and immunotherapy together. leukemia can be, cured more efficiently, compared without this imatinib. This is an example from children oncology group. Historically, this type of leukemia event-free survival was not good. Diagnosis from time from diagnosis, survival about 30% in the 5 years. Now, by adding imatinib, this is significantly improved. Used to be these patients transplanted, but now even without transplant, chemotherapy only, they have equivalent outcome, those compared with those who get transplant. Of course, we have to think carefully about, monitor carefully for the chemotherapy only group for the long term. And then this means significant improvement outcome was done by adding imatinib to chemotherapy targeted agent. And now we have a newer generation of tyrosine kinase inhibitors such as dasatinib and ponatinib. Lastly, immunotherapy is a new area. Bispecific antibody, CD3, CD19 antibody called blinatumomab, and CAR T cells, chimeric antigen receptor T cells. There are several kinds now in the research, and the CD19 CAR T cells in the FDA approved. And the other medication is the antibody drug conjugate. Antibody bind to leukemia, and this chemotherapy attached antibody. So drug is delivered to the target cells. Antibody drug conjugate, people call ADC. I'm going to show only blinatumomab here today, but blinatumomab is a CD3 antibody. It binds to T cell. This attack the target. CD19 antibody, this binds to leukemia, B cell leukemia. They get close, and T cell attack the leukemia and kill. At that time, chemical cytokines produced. So these use patient own T cell to attack leukemia. And then half-life is 2 hours. Therefore, they have to carry the bag for 28 days to infuse continuously. And this is approved for pediatric adult relapse refractory and MRD positive ALL. And the side effect is cytokine release syndrome or neurotoxicities. And then in the relapse setting, the chemotherapy is given, and then patients are divided to continue chemotherapy or 2 courses of blinatumomab. And then blinatumomab was better compared to chemotherapy in terms of disease-free survival in this children oncology group study. And then importantly, no toxic death compared to chemotherapy only. And then this ratio, fever neutropenia, 40% plus 4%. Infection is much less. Sepsis is much less. Mucositis is much less. So this is, less toxic and most likely more effective. Of course, cytokine release syndrome and neurotoxicity is a newer side effect, but this may be better in terms of less infection, so might be beneficial for the patient who are having B-cell leukemia. It is also shown it's beneficial in the infant leukemia, historically very difficult to cure, survival 66%, 65.8%. Historically, these induction protocol 1B and these chemotherapy was given, but adding blina in this second phase, outcome increased to, this blinatumomab increased 93.3%. So remarkable change as seen with the blinatumomab. So as a summary in my part, ALL is the most common cancer in the children. And then it is fast growing cancer that starts in lymphocytes. Bone marrow makes too many immature leukemia cells. Therefore, anemia happens, red blood cell decrease and cause fatigue, low platelets cause bleeding, and decreased white cell count or leukemia by itself cause fever. The survival of ALL improve in high-income countries. And then this is made possible by risk-based therapy, clinical factors, genetic and MRD. However, we are in 94, the intensive conventional historical chemotherapy is raised to limit. Therefore, we have to use new approach to really want to go to 100%. That's our goal by using molecular target therapy and immunotherapy. So now we are bringing, our team next fantastic family nurse practitioner, Miss Ashley Horan, gonna explain about side effects.
Hello, welcome everyone. So today I want to talk about side effects as it relates to leukemia therapy. And before we can talk about side effects, I want to start by talking about supportive care. So what is supportive care? So your child's team, along with the doctors, nurses, advanced practice providers, will include a multidisciplinary approach. These include pharmacists, social workers, physical therapy, palliative care, chaplains. All of this team together works together to help relieve symptoms that are caused by cancer itself or the treatment of the cancer. It may be important for you to ask your provider for a complete list of side effects so you'll know what to look out for each medication your child is receiving. It'll be important to tell your child's team about any new symptoms they may have or changes in how your child's feeling so we can address these early and prevent severe reactions. So when you talk about side effects, we have acute side effects, and those are the side effects that are seen most often immediately after the chemotherapy is given. All cancer therapy can cause side effects, but as Dr. Inaba talked about, it all depends on multiple factors: the individual patient, the type of drug they're receiving, and the dose that they're getting. There's also late-term side effects, and these may take years to develop, as Dr. Inaba was talking about, obesity, risk of secondary cancers. So it's important to remember, even after your child completes therapy for leukemia, to have a primary care physician that gets to know your patient, the patient's history and the medications they were given and what to look for. So today I'm going to discuss the most common side effects. So it's important to know that all cancer therapy can cause side effects, and every child will receive some side effects, but not every child will receive every side effect. Some of the most common we'll talk about are low blood counts, infection, nausea, vomiting, nutrition changes, allergic reaction, skin changes, hair loss, mouth sores, peripheral neuropathy, steroid side effects, chemo brain, immunotherapy side effects, and pain. So low blood counts. Chemotherapy is the medication that we use to help kill the cancer cells. But in doing so, it also impairs the ability of your body to make all blood cells, like Dr. Inaba talked about: red blood cells, white blood cells, and platelets. So we monitor these levels by looking at the complete blood count, which is a blood test, also known as a CBC. When the red blood cells are low, that's called anemia, and that red blood cells help the oxygen go from the lungs to the tissues. So when the child is anemic, you may notice they have headaches, fatigue, they're pale, they may be more irritable, they may complain of fast heart rate, they may be dizzy. And so when those occur, the CBC will show us a decrease in the amount of RBCs by looking at the hemoglobin. And once the hemoglobin gets between 7 and 8, your child may need a blood transfusion to help increase those numbers. When the white blood cell is low, that's called neutropenia. We notice that on the CBC as well as the ANC, which is the absolute neutrophil count. So when those are low and the ANC is below 500, we consider that severe neutropenia. Why is that important? That's because when a patient is neutropenic, they're at increased risk of severe infections. Platelets, those help stop bleeding. We look at those on the CBC as well. And when those get below 10 to 20,000, your child may need a platelet transfusion. So infection is one of the most common side effects that we see from leukemia treatment. The reason is because the therapy that we give causes the immune system to be weakened. It's important to remember that fever may be the only symptom that your child has, and it's often the only sign that they have. But there are cases where children have infections and they don't have fever at all. So other things to look out for are chills or sweating, sore throat or sores in the mouth, stomach pain, pain in the anal area, pain or frequent urination, diarrhea, cough, shortness of breath, or redness, swelling, or pain of the skin. It's important that if your child has a fever or any symptoms of infection to call their provider immediately. We want prompt initiation of antibiotics when they're neutropenic, because these patients can have a severe infection that progresses very quickly without treatment. So if you don't remember anything else I say today, remember this: fever in a child undergoing therapy for leukemia is considered a medical emergency. What is a fever? So a fever is a single oral temp greater than 38.3 Celsius or 101 degrees Fahrenheit, or a temperature of 38.0 Celsius, 100.4 Fahrenheit or higher, that is sustained over a 1 hour period. How do you take a temperature? So oral and axillary are the preferred methods to take temperatures. If your child is too young to take an oral temperature, or they have mouth sores that prevents them from getting an accurate temp, you can do an axillary temp under the arm. It's important to remember that the temperatures are different when you do an oral temp versus an axillary temp. And usually if you're doing if you're measuring the temperature Fahrenheit, you will add 1 degree to it if you take it under the arm. There's also a temporal and tympanic methods of taking temperatures, but we recommend that you check with your provider before you use these methods, as they may be less accurate than the oral and axillary readings. I want to point out that we do avoid rectal temperatures in cancer patients. They have weakened immune systems, and the area around the anal area is very thin and can easily become damaged with a rectal thermometer. So some skin changes that we see are very mild and just bothersome, such as darkening of the skin and nails and an increase in acne. And some can be more severe. For example, hand-foot syndrome. And this is a reaction where the soles of the feet and the palms of the hands become red, swollen, and they may even develop blisters. So it's important to keep your child's skin moisturized. Another important factor is they are very sensitive to sun, so make sure with any sun exposure they use good sunscreen. Unfortunately, treatment for leukemia will result in hair loss. This is known as alopecia. Everyone loses their hair a little different. Some may come out in strands, some may come out in clumps, and it usually starts coming out around week 2 to 3 of therapy. It does not hurt when the hair falls out, and it's important to remember that it's temporary and it will grow back. It usually grows back around 6 to 12 months after therapy ends, but you may notice that it grows back different. It may be a different color or a different texture. We often see mouth sores with therapy for leukemia. These start out as like red, irritated places in the mouth. They may complain of burning, and then that progresses into white, open lesions that are very painful. It's important to have good mouth care, and we will be prescribing mouth rinses that are important to use to help prevent the mucous membranes from becoming infected. If your child does have the mouth sores, there are options that we can use to help treat them, such as pain medication, mouthwashes that numb the mouth or coat the ulcers. So it'll be important for you to let us know if you notice any mouth sores at all. For nutrition, all patients undergoing therapy for leukemia are going to have to take steroids, and this will result in an increase in appetite and subsequently weight gain. You may notice that your child has very swollen cheeks or a protruding abdomen, and that is completely normal and will go away with once the steroids are stopped. At other periods throughout the treatment, you may notice your child has some weight loss. This may due to many reasons throughout therapy. It'll be important to let your team know. We can get the dietitian involved, and sometimes your child will need supplements to help increase or obtain their nutritional goals. Most often those are liquid supplements such as Pediatric, and we also have medications that can help with appetite as well. Also, we notice appetite and taste changes. You may notice that your child is not eating their favorite foods anymore, or they may be craving specific foods. We often see kids craving salty foods, spicy foods, and this is all due to the taste changes that occur during therapy. So nausea and vomiting is very common as well. Your child will be given medications to help prevent nausea and vomiting. And it'll be important that they take those as prescribed. The best cure for nausea and vomiting is to prevent it in the first place. If your child is experiencing nausea and vomiting, the nursing staff and the providers may use this BARF scale here to describe how severe their nausea is. If they are having nausea and vomiting, it'll be, again, important to take the medications. You want them to drink enough fluids to help stay hydrated. You may have to do this small, frequent amounts throughout the day. You want to do small meals. Avoid heavy, spicy, greasy meals. And then we can talk about the BRAT diet, which basically is a bland diet. BRAT stands for bananas, rice, applesauce, and toast. It can be a combination of any of those, but it's just more bland foods that can help. Unfortunately, your child may exhibit some type of pain during therapy, and this is for multiple reasons. But it's important to know that there are many non-pharmacological and pharmacological methods to help address and treat the pain. There are different pain scales that we can use to determine how severe your child's pain is. This pain scale is the verbal pain scale, and that's for the children usually above 7, and they can rate their pain verbally. 0 is no pain at all, to 10 is the worst pain. For children less than 7 and up to about 3 years old, or children that cannot verbalize their pain, we can use this. It's called the FACES pain scale. And we offer this scale to the patient, and they will point at what face they feel like it describes their pain. And then for patients that are younger than 3 or patients that are nonverbal, we have a FLAC scale. And this is where the staff will rate their pain based on their facial expression, their leg movements, their activity, their cry, and how easy they are to console. It'll be important to remember that sometimes if we need pain medication, we have a pain care management team that is available, as well as palliative care that can help manage their pain. So chemo brain, what is chemo brain? So this is changes in cognitive function during a cancer therapy. And you may notice, or your child may notice, that they have a change in their thinking, attention, or memory. We don't really know what causes chemo brain, and most often it is temporary, although some can be long lasting. So some tips to help is try to maintain a schedule as much as possible, and you can use memory aids to help. And you try to keep them focused on their activity and try to limit distractions during busy periods. So all our patients, as I talked about before, will get steroids, usually prednisone or dexamethasone. And these can cause a variety of side effects. High blood pressure, high blood glucose. These are things that your nurses and doctors will monitor by checking their vital signs when they come to clinic and doing blood work. Your child may need medications to help get their blood pressure stabilized and to keep their glucose under control. We talked about the increased appetite and weight gain, and this is very common with steroids. And acne is usually seen in the teens and young adults. So it's good to keep their skin clean and dry and good skin care. The main thing I want to talk about is the behavior and sleep changes. You may notice that your child is more active or hyperactive. You may notice they cry more than usual. They have anger outbursts. They go from being happy to sad to angry very quickly, just very emotionally labile. And they may have trouble getting to sleep or falling asleep. Just know that this is normal and it will go away once the steroids are stopped. And it may be important for you to ask your team to have psychology help. They can teach your child how to comfort themselves. They can teach you how to cope with their behavior changes and how to comfort them as well. Vincristine is another drug that all leukemia kids get. And the 2 main side effects I want to talk about with that is peripheral neuropathy and constipation. Neuropathy is a problem with the nerves, and it usually starts in the hands and feet. It can be described as numbness, tingling, pain. You may notice muscle weakness. You may notice your child is having difficulty walking because they cannot lift their foot as well as they could before. If those occur, we can give them medications to help with the neuropathy. And it's also important to have them see physical therapy and occupational therapy. This can really help with their physical restrictions. Constipation is very common, and so we encourage the patients to drink and stay well hydrated and stay active. And if that doesn't work, you may have, your child may have to take a stool softener or a laxative to help prevent constipation. Asparaginase, this is another common drug that your kid will get. And unfortunately, it can cause quite a few side effects, but your child will be monitored closely during the medication administration. One thing to look for is an allergy or a hypersensitivity reaction. You may notice they have a rash, itching, swelling, cough, trouble breathing. Sometimes we give medications beforehand to help prevent the reaction from happening. Other times we have to stop the medication, treat the reaction with medications such as Tylenol and Benadryl, and sometimes steroids. And then we'll decide at that point, depending on the severity of the reaction, if we continue on with the medication. Pancreatitis is an inflammation of the pancreas, and it causes significant persistent abdominal pain that may radiate to the back. If your child develops pancreatitis, they may have to be admitted to the hospital for symptomatic therapy, such as IV fluids, pain control. This is a blood clot, and asparaginase can increase your chance of having a blood clot or thrombosis. If your child is to develop one of these, they'll have to be placed on medication to help make the clot smaller and prevent from new clots from forming. The length of therapy for your anticoagulation will depend on where the clot is and why the clot formed. Another organ we monitor closely during asparaginase is the liver. We may notice some liver dysfunction, and this is common. Sometimes we have to adjust the dose of the medication, and sometimes we have to hold the medication until the liver responds. Again, these are temporary, and they will usually resolve after therapy with no long-lasting effects. So Dr. Inaba talked about the new immune therapy, specifically blinatumomab. We know it works by targeting CD19 cells found on B ALL cells and some normal B cells. When a patient gets blinatumomab, they will be admitted to the hospital and stay inpatient for the first few days. We want to monitor them closely for side effects. As Dr. Inaba talked about cytokine release syndrome. This is important, and it usually occurs pretty quickly once the medication is started. They will present with fever, chills, weight gain, muscle joint pain, headaches. They may have seizures. They may have vomiting and diarrhea. If your child does have CRS, they may have to be moved into the intensive care unit for monitoring to support them. Sometimes the child will need dialysis to support kidney function, IV fluids to promote hydration, and medications to promote optimal heart function. We also monitor the central nervous system for reactions, and this is where the parent will come into play. You may notice a change in the way your child is responding. They may be forgetful or not remember things. You may notice that their handwriting has changed, or they're clumsy or falling. Let us know if you see any of these changes in your child. If your child has a risk for seizures, they will be put on a medication to help prevent seizures. So low gamma globulin. Gamma globulin are proteins in your body that help fight infections. Blinatumomab decreases these immune globulins in your blood. So we monitor them every 4 weeks by looking at immune globulin G. If that level is low, your body cannot fight off infection, and they may be sicker for longer periods of time. So under 400, we will supplement with a medication called IVIG to help their body respond to infections. And again, pancreatitis is also a side effect of blinatumomab, so you would let us know immediately if your child has any severe abdominal pain.
Hey guys, it's nice to see you all. So my name is Brad Moeller. I'm a clinical fellow here at St. Jude, working under the mentorship of Hiroto Inaba, and Ashley, Hiroto, and I work as quite a team with many patients. I'm a patient advocate, and so I think it's important to go over my story, and then I'll give you guys some tips on how to advocate for your children going through therapy. So to start with, there's me. This is back in 1998. This was when I was first diagnosed, over the holidays, of course, and we'll get into my story in just a minute. And so I think it's important to understand how I presented with my symptoms, because I think it's going to resonate with a lot of you guys on how your children present with theirs, as this was a very common presentation for this disease. So I first developed about 3 weeks of fever. I had some fatigue, some loss of appetite, and I was evaluated by my pediatrician once a week with the initial thought that this could probably be a virus. And so I would see the pediatrician once a week while I was going through this, and then eventually my symptoms weren't getting any better, and I developed difficulty breathing. After that, after my pediatrician noticed I was having trouble breathing, they drew some labs and then attained a chest X-ray. What the labs had shown is that my white cell count was beyond the quantification limit of the assay at greater than 900,000. And that the chest X-ray revealed a large mediastinal mass. After those were found, I was soon diagnosed with T-cell acute lymphoblastic leukemia at the age of 7, again, around 25 years ago. My treatment included 2.5 years of chemotherapy and radiation to my brain and spine. But honestly, during that time, it wasn't all bad. At first, sure, it was traumatic. But then, as I was going into treatment, I developed really close relationships with my oncologist and the medical staff taking care of me and my family. And it was over those years of therapy that I decided that I wanted to take care of kids that were just like me. And it's ultimately what made me want to be a doctor. And after those years of therapy, I've had no recurrence, thankfully, of this malignancy and have been determined as cured. And so I'll give you some pictures from me going through treatment just so you can see how the different phases are. So on the left-hand side, you'll see my whole family. I'm sure you guys can tell it's my dad. And then my mom and me in the middle. You can tell that I was pretty skinny at that point. It was after my first hospital discharge, and I had spent several weeks in the hospital getting really intense therapy because of the way that I presented. And then you see my little sister, Brooke, sitting next to me. At this point, this was back in 1998, we didn't have the risk stratification like Dr. Inaba went over. We couldn't really predict on which kids would do well and which kids wouldn't. But the way I presented was pretty dramatic with that kind of white cell count. And so my parents were told that my prognosis would likely not be good. So it was this time that we started taking lots of family photos and did a lot of things together. But thankfully with therapy, I responded well and didn't need anything afterwards. But as I continued on through therapy, as you can tell on the picture on the right, that's when the steroids hit. I definitely had taste changes. I liked very salty things and things that were spicy because you could actually taste those on your taste buds that were abolished by the chemotherapy. And I like to eat everything. And apparently I was pretty hangry and irritable throughout that period too. And so if I was given food, I was happier. And so my parents were happy with that. But it wasn't all bad. I ended up going on a really awesome Make-A-Wish trip where this was again in 1999. So I was about a year into therapy. My Make-A-Wish was to meet George Lucas, the guy who made Star Wars. At that time, it was he was a pretty busy man because he was making The Phantom Menace, but he made up for it in a lot of ways that I didn't actually get to meet him in person. So the picture on the left is me with Rosie O'Donnell, who was big in the 1990s, but I got to attend the world premiere of The Phantom Menace in Chicago at that time and was literally sitting next to Michael Jordan and his son. And then they took my family to the Sacramento, California area where I got to tour the Skywalker Ranch before it was open to the public and got to try on costumes with me and my sister and play around with motorized R2-D2s. And it was a really cool experience. And so I encourage all of my patients nowadays who have Make-A-Wish, make a cool trip out of it because I had a wonderful trip with mine. And then the picture on the right is me, again, farther on through therapy, still very much on the steroid phase, where you see that moon face that I have with the puffy cheeks and the large abdomen. Eventually it went away, though, I promise. But this was with me and my family, and then the person behind me was a camp counselor that took care of me a week every year that I would go to this camp called Camp Quality, which was filled with other kids that had cancer, and we got to receive all the care we needed at the camp and got to be like normal children going to a summer camp, which again is rare when you're going through therapy. This eventually led me to St. Jude, where I ended up doing my undergrad training in biochemistry and then went to East Tennessee State University up in Johnson City for medical school. And it was while I was in medical school, I applied for this pediatric oncology education program that's meant for people wanting to go into the field and focus in on science. And there's me in the background. And this was, again, back in 2015. And it was at this time that I actually met Dr. Inaba and worked under the mentorship of a mentor of mine, Brandon Triplett, who's a bone marrow transplant doc. It was during this experience that I was able to do some really amazing research with Brandon Triplett, which you see that picture on the left. And again, this was still while I was in medical school. And then after medical school, I did my pediatrics training at Johns Hopkins in Baltimore. And these are me and my folks just a few years ago at my graduation. Now, I think it's important that you guys get a good picture that although it's very heartbreaking to hear that your child has cancer and that has 2 to 2.5 years of therapy, afterwards, they can do something very productive with their lives. And when I got here, I made incredible mentors and coworkers, and this is the team that I work with almost every day. And so now to get to the point of how to advocate for your child with cancer. So a lot of this comes from literature, but also personal experiences as I watched my parents navigate that for 2.5 years. And so the first advice that I can give you all is to ask questions. Physicians are really bad at taking something that's complicated and explaining it simply, and there's nothing simple about ALL. And so if a physician or someone on the care team is explaining to something to you and it's in a foreign language and it doesn't make sense, ask them to repeat it, slow down, explain it in a different way so you get a general understanding on what it means. And I know that you all have been through the consent process and how that goes, where you're given a 100-page document and expected to remember all that, and you only remember a few things from that. And it's afterwards that you should take the time to ask those questions and write them down for your providers. So really just ask and don't feel bad about asking. That's what we're there for, to help navigate those. Share your concerns. So all of this is going to be new to you. A lot of you aren't going to know what ALL is to begin with before your child is diagnosed. Nonetheless, what the complex treatment regimens are. And so if you see something different with your child, be sure to share those concerns with your treatment team so we can assess, is this treatment related? Is this related to the cancer, or is this not? And in that sense, we can provide reassurance. None of your concerns are invalid, and even if they're small, just ask your medical professionals. This is part of advocating for your child. Get organized. This was the #1 for my mom, but it's also based in the literature as well. My mom always had a notebook, and in that notebook, she would literally write everything down. She knew every medication I was on, the doses I was on, the times of the day that I was supposed to be given those medications, when my appointments were, where they were, how to get to them. She was very organized with them. And I know because of how type A she was with her organization, it contributed to my good outcome. So take notes, write things down, get organized. And furthermore, these notebooks that you create can be a place that you write down those questions that you think of at different times in therapy that you may not be near a medical professional, so you can bring it up to them the next time you see them. And then also communicate with your child. Even if your child is young, they're going to know that something is wrong or something is wrong with their body because they're going through treatment for so long. So it's even important to share with your younger children that yes, they have cancer, yes, they have leukemia, but yes, it's curable and treatable. And so tell them you love them, tell them that they are strong and that you're going to be there with them to get them through this. And be honest with them. Even your younger kids will understand it. Make sure to take care of yourself. there's going to be a lot of things going on in the 2.5 years of treatment, and it would be very easy to just focus on your child and forget about care to yourself. But it's very important to care for yourself too. So make sure you're eating well, exercising, and doing the things to keep you physically and mentally strong so you can be there 100% for your child. And lastly, what I want to bring up is find support. At the centers that your children are being treated at, you're going to find lots of families whose kids are also being treated for cancer. You may even find families that have children being treated for the same type of cancer. And so sitting down with those families and sharing your experiences can help you cope through this trauma that you all are enduring with your children. Furthermore, social media nowadays has allowed lots of family groups to get together to share their experiences, to know that you guys aren't alone. And with that, I'll open it up to questions and answers.
So I actually had a question for Brad, for Dr. Muller. When I was thinking about support for like parents, I do recognize that support for children is a little different, right? Like their support network will look different than an adult's. Do you have any recommendations for how children can have kind of like their own support group?
Yeah, absolutely. So your children are going to befriend other children at the centers that they're being treated at, for sure. I know I made multiple friends while I was there. And so sharing those experiences with those kids was extremely beneficial to me. But also your child's friends that they currently have prior to starting treatment will still remain their friends, right? And it's just important to approach those conversations with their friends on what they have now and how their life is going to be different over the next few years, and how they may not be able to see them as frequently, but still can be there for them. And nowadays, I have lots of patients who will play video games with their friends, and that's a way that they stay connected and still stay isolated while they're neutropenic or at risk of infections. And so I think there's lots of ways for your kids to stay supported, especially with their friend groups.
Great, thank you. So thank you for an informative presentation from Kenya. So there's a question is about how they had a 19-year-old patient with ALL who did not make it due to the severe toxicities. And so the question is about, is there a male predisposition to ALL?
Yeah, let me explain these issues. It's in my presentation, male to female ratio is about 1.3 to 1. And then partially T-cell leukemia is more common in boys. That explains the difference as a whole, and then boy and girls. So there is some, slightly more incidence seen in boys, particularly, partly due to the more we see T-cell leukemia in the boys. That's maybe, I hope I answer that, situation and then evidence that we have.
Okay, thank you. So again from Kenya about how, let's see, can we have access to some of the immunotherapy or molecular targeted therapy, because I'm guessing as a country, largely use conventional chemotherapy?
Yes, let me explain these issues. I think, this is very important that, we are working in the St. Jude Children's Research Hospital. We know that 80% of population, 80% of ALL patients are born in low medium income countries. In my presentation, I show the fact in the high income countries. However, we, including St. Jude Children's Research Hospital and others, need to think about globally. And then this also need, not only institutional effort, we need a help from the companies that makes the new agents. And then there are, activities such as imatinib is given to, relatively cheap price or free to the, countries who have limited resources. And also St. Jude Children's Research Hospital studied and the blinatumomab humanitarian access program is working with a company to deliver the pre-medication. The activity is still small, but eventually we get a lot of support from everybody in the world. We hope we can provide effective, less toxic, and then affordable therapy all over the world. That we are totally looking for, and we want to do this kind of work in the future, in the near future, and now actually.
Mm-hmm. Do you often get questions from providers around the world asking about what treatments they can use based on what's available in their country?
Yes, I work in the St. Jude Children's Research Hospital, and then I get almost every day, at least one or two, get a consult all over the world. And then I have to think about, what, resources available, and then we as a team provide, best possible treatment in that region. And hopefully this, many medications become available, and we can give a consistent same approach to everybody. But at this moment, unfortunately, not there yet. But that is the goal. We're gonna try. We keep going. We need a lot of improvement.
What can we do, if anything, during treatment to reduce the risk of long-term side effects like increased risk of heart disease, secondary cancer, etc.?
You okay? I'll take this one.
Take it.
So a lot of what Dr. Inaba presented at the beginning of the presentation was how we risk stratify patients. And so patients can be low risk, intermediate risk, or high risk. And with that risk stratification system, we can identify the children that we can cure with good certainty with lower amounts of chemotherapeutics. And so those kids will have less toxicities. It's unfortunate for the kids that have high risk disease because they require more intensive therapies for us to have good outcomes at cure. But nowadays, we are doing lots of research on how to implement, how to use all of those novel immunotherapies that Dr. Inaba presented as an upfront therapy as opposed to using it as relapse therapy, because we notice less side effects when we use those, especially related to cardiac disease or secondary malignancies.
And then I add one more thing. We are investigating genes, what's causing leukemia. And if we find any driving specific gene that drive leukemia, we may able to find in the near future that particular block that gene not affecting other part of the body. That hopefully decrease side effect in addition to immunotherapy. We are many things to do to improve not only even cure, we cure 94% high income country, but we have many things to decrease toxicity as well as treatment in the low medium income countries.
Thank you. So the next question is about multivitamins, if there's a certain kind that they should provide for children, and what kind of food should we encourage children to eat. For my patients, some parents are afraid to eat red meat during treatment, for example.
Yes, so during therapy, we do not recommend any multivitamins. And if you are going to take any type of multivitamin or supplement, to discuss with your care team before taking it, because sometimes those can interact with the chemotherapy medications that we're giving your child, which can increase toxicities or can make the chemotherapy less effective. As far as the types of foods, we just recommend safe eating, which means washing the fruits and vegetables very good before eating, throwing any food out that's been open for more than an hour. If you get any food to go at a restaurant, let them know your child is undergoing therapy for cancer and that they need to make that fresh for them. We do say avoid non-pasteurized tea, and avoid fried rice, and avoid pepper.
Yes, and then vitamin issues, folic acid is an antidote of methotrexate. Methotrexate is given usually weekly, so it may block the effect of methotrexate. So when as Ms. Ashley Holland said, you should discuss with the primary doctor and care team.
How do we measure progress during treatment or effectiveness of the chemotherapy medications?
Yeah, so like Dr. Inaba said during his initial presentation, we use something called minimal residual disease, which is where we can look at the cells within the bone marrow and identify the cells that look like the leukemia. And based on the method that we use, we can find anywhere from one malignant cell in 10,000 normal cells to one malignant cell in 1,000,000 normal cells. And so we use those MRD assessments at several points throughout therapy, which gives us a sense on how well a child is responding to the current therapies, or if they're not responding, they allow us to change therapies to something that may be more effective. And so it's really all based on MRD assessments throughout therapy.
Okay, thank you. Let's see. Any pearls to offer on the use of serum asparaginase activity testing and when to consider changing therapy?
Yes, it's a very important question about asparaginase. We have now changing the formula, and then now we are using asparagase, which is a very prolonged half-life. So, we just started, using, especially last December, and we are still, need to learn more. And then because of long activities, if patient especially developing hyper, triglycemia, high lipid, or any side effects, it maybe makes sense to, check what the asparaginase activities are. And then by having this new formula, we are still learning quite a few issues, and because asparaginase activity is prolongedly active. So that is, I think, if patient, especially suffering from side effect from asparaginase, it makes sense to measure asparaginase activity, and the answer is yes.
So you mentioned the half-life. Do the side effects continue? I mean, maybe you can explain half-life, and how do the side effects continue because of the drug half-life? Is that also part of it?
Yes, it's, we are still learning, but half-life is expected 3 weeks, means asparaginase activity lasts more than 4 weeks. So if patient developed early, immediately after asparaginase administration, asparaginase can be still active, and while even patient having some side effect. So these issues we are still learning, and then we may know more in the very near future. And then I think we know that many patients treated already, but we still need to learn.
Mm-hmm, mm-hmm. So this next question, I think, ties into this other question I also have, and it says, my child was taken off of Asparaginase due to pancreatitis, and how will this affect his outcome for T-cell? And I think that ties into, which I think is the common question of, when you're taken off a drug because of side effects, what does that mean? I think people worry that if there's side effects and you're taken off a drug, that what's next? What are the other, like there aren't options. And so maybe you could clarify that.
Let me answer these questions. Yes, side effect is, sometimes it's because asparaginase side effect, if severe, we may not able to continue it. And then this usually, we replace with other chemotherapy, and hopefully this, overcome these issues. Of course, there is a data that patients who miss asparaginase quite a lot may be associated with worse outcome. But by giving alternative medicine, hopefully we can overcome. And especially T-cell is limited, medication available, but by giving, for example, methotrexate, and we are, some patients get nelarabine, and new medications available, so we may able to overcome. And then we don't know yet, patient, has a sensitive to asparaginase, can be leukemia is also sensitive. That's, we don't know yet, but, if so, maybe, stopping asparaginase due to toxicity might be okay, but this is, we need more investigation. At this moment, data shows that who couldn't get asparaginase, the full dose is associated with a worse outcome, and which we need to overcome by giving alternative medicine.
So when you talk about investigation, are we talking about clinical trials? Because there is a question about, is there a clinical trial about blinatumomab into first-line treatment?
Blinatumomab. Yeah.
First line.
It is still in the front line. It's in the pediatric. It is proven that blinatumomab front line in the infant leukemia, and then several groups such as children oncology group and the Italian German group are testing blinatumomab in the randomized way to whether blinatumomab will help in efficacy or decrease toxicities. I think the result is coming within the 5 years, hopefully. And then we can learn these issues, the effect of a frontline more. But it seems like very effective, attractive medicine in the frontline setting.
Okay, thank you. So I want to thank you for attending, and the NCCN Foundation would also like to thank our corporate supporters of this webinar. Thank you again, everyone, so much. It's very informative. Thank you for taking your time out of your day to join us.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye-bye.